Good afternoon, Excellencies, ladies and gentlemen. Welcome back to the Chamber. Many thanks for bearing with us, and many thanks for making your journey into New York and contributing to this, for us, very important event of understanding more, hearing more, and listening more to you. I call to order the interactive multi-stakeholder hearing as part of the preparative process for the high-level meeting on universal healthcare coverage. This meeting excuse me, is held in accordance with Resolution 75/315 of 17th of August 2021. I warmly welcome you once again to this meeting. This interactive hearing offers an opportunity for participants to benefit from the perspectives of all stakeholders on urgent actions and investments in health to accelerate progress towards the achievements of the universal health coverage by 2030, and to identify concrete milestones towards achieving this goal. The multi-stakeholder hearing will also assist in identifying the themes of the multi-stakeholder panels of the high-level meeting later in September. So, ladies and gentlemen, if you would allow, I would make some comments on my own to kick off our discussions today. Madam Deputy Secretary General, Madam Moderator, Madam Mr. Director, Assistant Director General, Excellencies, ladies and gentlemen, it is with great pleasure that I welcome you all to this landmark hearing on universal health coverage. We are here to discuss one of the most pressing issues of our time. In 2019, world leaders gathered in this very room to endorse an ambitious political declaration which reaffirmed their commitment to achieve the UHC by 2030. The universal health coverage means that everyone, without discrimination, can access the health services they need without fear of financial ruin. The UHC concept places special emphasis on women, children, those in need, and the most vulnerable. Thus, the UHC is not only about health, but about social inclusion, gender equality, poverty eradication, and the protection of human dignity. Martin Luther King once said that of all the forms of inequality, injustice in health is the most shocking and inhumane. The right to health is a fundamental human right. Yet billions in the world still lack reliable access to basic and essential health services. Meanwhile, health expenses push tens of millions of people into bankruptcy or heavy indebtedness every year. Today's meeting comes at a very special moment. Just a few months after the declaration was adopted, the most extreme health crisis in recent history broke out, the COVID-19 pandemic. It unveiled the vast disparities in access to healthcare, and its effects also visibly deepened inequalities. Now it is official that we have the global pandemic behind us. But we should always draw lessons from complex crises like the one caused by the COVID-19. The devastation brought about by the pandemic serves as a stern reminder that when health is at risk, everything is at risk. When anybody is at risk, everybody is at risk. That providing health is not a money pit, but a smart long-term investment in sustainable development. ladies and gentlemen, the achievement of SDG 3 is indivisible from the rest of the 2030 agenda. The pursuit of UHC for all truly encapsulates the interconnectedness of every challenge we face and every solution we have to them. When it comes to our goals, we are far off track. If we want to achieve our targets in time, we have to change gear. But we also have to change the whole game. As a part of that, we should give UHC its full due. We must recognize that it is not just a political commitment, but also a tool for socio-economic prosperity and the reduction of inequalities. And we should keep in mind that ultimately the aim of the universal health coverage is to leave no one behind. Dear friends, we live in crisis time. To tackle the many challenges we face, we have to mobilize all of our capabilities. We cannot rely only on what governments know and wish to do. We need each and every stakeholder on board. We need all of you on board. That is why we turn to you. That is why we ask you to bring here all your expertise, all your experience, ideas, and suggestions. Put simply, we need your wisdom and commitment. Soon, the floor will be yours. Together with the representatives of the member states, I'm eager to listen to your views on how we can have a world where health is not a privilege anymore. Thank you very much. I now invite the Deputy Secretary General of the United Nations, my good friend, Her Excellency Amina Mohammed, to make a statement.
Thank you very much, President of the General Assembly, His Excellency Shaba Korossi, my sister, Excellency Gabriela Baron, the co-chair of the UHC 2030 Steering Committee, and of course our Director General of WHO, ably represented by my friend Dr. Bruce Elwood. Excellencies, ladies and gentlemen, it's my real pleasure to join you here today, and allow me to thank the President of the General Assembly again for convening this important dialogue on universal health coverage in the midst of many global crises. Yesterday, I was privileged to be here as you convened on tuberculosis. Everyone has the right to health and medical care, a right recognized in the Universal Declaration of Human Rights and the Constitution of the World Health Organization. But hundreds of millions of people in rich countries, as well as poor, cannot exercise this fundamental right, thus deepening the inequalities. Millions of people are impoverished by healthcare expenses every year, and this is pushing them into hunger and destitution. Universal health coverage is the world's agreed pathway to delivering on everyone's right to health. Inclusive, sustainable development that leaves no one behind is only possible when everyone has access to the medical care that they need. It is both a key target of the Sustainable Development Goals and an enabler of the 2030 Agenda as a whole. It is deeply entwined with other goals, from ending poverty and hunger to achieving gender equality and economic growth. Excellencies, ladies and gentlemen, the COVID-19 pandemic cast a spotlight on how fundamental good health is to every aspect of our lives and how fragile our access to health is. More than 90% of countries reported that the pandemic disrupted essential health services. Some 25 million children under 5 missed out on routine immunization. A tiny virus showed us the infinite value of accessible, affordable public health services, and yet the fragility of our health systems today. While the race for vaccines demonstrated the importance of cutting-edge innovation and research, unequal access to those same vaccines prolonged the pandemic's impact and made recovery much harder for many countries, especially in the developing world. and we have still not yet acted on the lessons of the pandemic. Our investments in health are already dropping in many places to levels lower than before the pandemic. SDG 3 on health is among the 1/3 of SDGs that have stalled or gone in reverse. Progress on important communicable diseases has stalled or even reversed, including major killers like tuberculosis and malaria. And where we have seen progress in other areas like maternal mortality, it is still insufficient to meet our 2030 targets. Although COVID-19 is here to stay, as the pandemic recedes, we have the opportunity to change course for a better future. Urgent political commitment, attention, and action on universal health coverage is key to turning the situation around. This means, first and foremost, investing more and better in primary health systems so that they are resilient, equitable, and capable of meeting the key health needs of today and the challenges of tomorrow. This means reorganizing health systems to focus on goals that not only manage disease, but also produce a good health. It also means investing in health promotion and disease prevention and prioritizing interventions that address major risk factors: tobacco, unhealthy diets, harmful use of alcohol, physical inactivity, and air pollution. This to optimize health and well-being throughout the life course. Every year, 17 million people under the age of 70 die from non-communicable diseases, 86% of whom live in low and middle-income countries. Many of these early deaths could be prevented. Universal health coverage is essential for individuals to enjoy their full human rights, and it brings important benefits to societies and to economies. Where health systems are strong, people live longer, they're healthier, happier, and much more productive. Societies then are more resilient to shocks, and we are better prepared for future pandemics and other crises. Excellencies, ladies and gentlemen, the high-level meeting on universal health coverage in September will be an opportunity to bring a sense of new urgency and policies to strengthening health systems for today and for the future. Leaders must act now to design and provide resources for health systems that are people-centered, integrated, and equitable. Government financing will be paramount. In low-income countries, external aid accounts for an average of 29% of health spending, which is more than national spending. This is not sustainable. On health financing and the workforce, there's a global shortage of 15 million health workers in 2020 and a projected decline in the shortage to 10 million by 2030. This too is unacceptable. We need global and local solutions, and we need them now. We need an inclusive approach that brings in all stakeholders, including the private sector, healthcare workers, civil society, community workers, academia, and more. The high-level meeting on universal health coverage will be a critical opportunity to make concrete gains. We need each and every member state to commit to radically reorienting health systems to provide quality primary health care. We need them to be held accountable for leading the progressive realization of SDG 3 and health for all. This is one of the most important political choices a government can make at the national as well as the international level. The entire UN system stands ready to accompany you. Health for all is key to addressing inequalities and advancing the SDGs. We cannot achieve sustainable development without it. The time to act is now. Thank you.
I thank the Deputy Secretary General for her statement. And now I invite members to view the pre-recorded statement by Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization.
Your Excellency Chaba Koroshi, President of the General Assembly, Your Excellency Caroline Rodriguez Birket, Permanent Representative of Guyana, Your Excellency Sureya Jindawong, Permanent Representative of Thailand, Deputy Secretary General Amina Mohammed, the Honorable Gabriela Baron, Co-Chair of the UHC 2030 Steering Committee, Excellencies, dear colleagues and friends, The political declaration on universal health coverage that leaders adopted in 2019 was a landmark commitment to realizing the right to health in all countries. Little did we know then that the COVID-19 pandemic was just around the corner. COVID-19 disrupted health systems around the world, depriving millions of essential health services and setting countries back in their efforts to achieve universal health coverage. Rising out-of-pocket payments are making financial risk an increasing barrier to care for people around the world. As you know, on Friday, I declared an end to COVID-19 as a global health emergency. However, the effects of COVID-19 will be with us for some time. Progress is only 1/3 of the pace needed to reach the SDG target on UHC, and we need urgent action to get back on track. As the world recovers from COVID-19, this year's high-level meeting is a vital opportunity to rekindle political commitment supported by evidence-based priorities to drive progress. In all countries, national health plans are the essential pathway, with a focus on strengthening health systems through a primary health care approach. Primary health care can deliver around 90% of essential interventions and could save an estimated 60 million lives by 2030. It's also crucial to global health security. This multi-stakeholder hearing is an important opportunity to hear from a diverse range of stakeholders and to exchange views on key priorities for the high-level meeting and its political declaration. Let me highlight 3 priorities for your consideration. First, WHO calls on all countries to invest more and invest better through health financing policies that provide equitable access to services and improved financial protection. Second, we call on all countries to take a whole-of-society approach. Engaging civil society organizations and communities is critical, especially for addressing the needs of marginalized populations and improving gender equality and youth participation. Our focus must be on the most underserved, especially mothers, newborns, and children. Third, we call on all countries to implement the commitments made in the Working for Health Action Plan for 2022 to 2030, so that every country has the national workforce capacity with decent pay and working conditions for public health, universal health coverage, and health emergencies. Thank you all for your commitment to realizing the vision of universal health coverage in every country and to a healthier, safer, fairer future for our world. I thank you.
I thank the Director General of the World Health Organization, and once again I wish to acknowledge the presence with us today of Dr. Bruce Aylward, Assistant Director General, Universal Health Coverage Life Course at the World Health Organization. I now invite Ms. Gabriela Cuevas-Baron, co-chair of the UHC 2030 Steering Committee, to make a statement.
President of the General Assembly, Shaba Qureshi, Madam Deputy Secretary General, my dear sister Amina Mohammed, Director General, Your Excellencies, ambassadors from Guyana and Thailand, advocates and friends. As co-chair of UHC 2030, I am honored to be here with you on this very important day. UHC 2030 is a global movement and multi-stakeholder platform to build stronger health systems for universal health coverage. We are here because we care, half of the world's population has no access to health services. We are here because health is indispensable to achieve any other SDGs. There is no possible well-being without health. We are here because we care for women working at the health and care areas who are not being paid equally as men and who are not represented at decision-making processes. Women are saving lives, but cannot express their own voices. Today, we stand at a critical juncture. Health for all can be a reality by 2030, but only if governments renew their commitment. The UHC movement published a very important document that came from a highly inclusive process, the Action Agenda. Indeed, those are the strong voices that are very much needed. Thank you. It contains 8 action areas that governments must not neglect. Let's be clear. UHC is a political choice. Governments have to place health at the top of the political agenda. This is a matter of political will. Governments need to define their own implementation route and make health a reality for the people that put their trust in them. Governments, both national and at local level, and of course parliamentarians, must abandon the false idea that health is a cost. It is not. Health is an investment. Health is not a privilege. Health is a human right. We also need the parliamentarians community, all 46,000 of them, to legislate for stronger health systems, to listen and to work with civil society and communities, to make governments accountable and transparent, and to allocate budgets that transform commitments into tangible results. We must all contribute, the private sector too, by improving research and development in the health industry, where each new medicine and technology can save millions of lives, and not least by taking on board that 70 million people are pushed to extreme poverty every year due to the cost of health services, treatments, or medicines. When we understand health as a human right, we also understand solidarity as a mandate for all of us. And for those who work the extra mile, for the civil society organizations, and especially those who help people and communities at the most complicated locations, first, our gratitude. But second, we need all of you. We need your strength for improving accountability and social participation. Women and girls are still discriminated. 21st century, and we are still fighting for our human right and equal representation. Countries must urgently strengthen the health and care workforce and guarantee equal pay and equal representation at all levels in health. Excellencies, UHC provides a coherent framework to bring all health agendas together. We need heads of state and governments to commit with concrete action with clear milestones. And we need all of us to do our part in turning words into actions and to stop giving money the power to decide who lives and dies. Health for all is possible. Together, let's make it a reality. Thank you very much, Mr. President, for this wonderful hearing.
I thank the co-chair of the UHC 2030 Steering Committee, and thank you very much for your inspiring words. I feel the huge energy and dedication in the room. That's exactly what we need to push all of us. The final leg is ahead of us. Until September, we have to make it. Thank you indeed. As indicated in the program, this interactive multi-stakeholder hearing also consists of 2 panel discussions and a closing segment. The first panel discussion, entitled Universal Health Coverage as a Driver to Accelerate Health for All, will be moderated by Dr. Gitinji Gitahi, Group Chief Executive Officer of AMREF Health Africa, and will take place immediately following this opening segment. The second panel discussion, entitled Universal Health Coverage, Commitment to Actions and Accountability, will be moderated by Ms. Elisha Dunn-Georgiou, President and Chief Executive Officer of the Global Health Council, and will take place from 4:30 to 5:45. The closing segment will take place immediately thereafter. Now I would like to ask the moderator of the first panel, together with the speakers, to take the podium. The opening segment thus is now concluded.
Thank you.
Hello, colleagues, friends, wherever you may be. I know there are people who may be watching us on UNTV, but for those of you who are here, good afternoon. Good afternoon. Thank you. I must, on behalf of this panel and on behalf of the President of the General Assembly, ask you to bring passion to this meeting and energy, because it's about lives. Thank you. And the member states who are here, we thank them for coming to listen to all of us, and therefore I now declare this session open. My name is Dr. Gitinji Gitahi. If anyone asks you who the moderator was and you can't remember the names, many people call me GG, so that can be easier for you. I am the Group CEO for AMREF Health Africa, a former co-chair for UHC 2030, and also a co-moderator for the Coalition for Global Health, which is bringing all of us together. I joined here by a panel of distinguished panelists who I will introduce right now, but I will ask them to speak a little later. We are joined here by Emilia Carracedo. She is the Secretary General, United Cities and Local Governments. We are joined by Nupur Lalvani. Nupur Lalvani is the founder, director, Blue Circle Diabetes Foundation. We're also joined by Mr. Mahmoud Al-Hamodi, who is the Vice President for External Affairs, International Federation of Medical Students Association. And last but not least, we are joined by Mana Cunningham, who is the Vice President, the Fund for the Development of Indigenous Peoples of Latin America and the Caribbean. Thank you, ladies and gentlemen, for joining us here, and we really look forward to hearing from you. But as moderator, I have an opinion as well. And I would hate to believe that the President of the General Assembly got me here without knowing that I would have an opinion on UHC. So I'll share very quick remarks, a 1-minute remark. The first thing I would like to do is to remind all of us here that we are carrying the hopes and dreams of 8 billion people for an equitable world where health is the foundation of all social, political, and economic development, as reflected earlier, because it's only healthy children who learn, and it is only healthy adults who earn. UHC is the guarantee, and it's also the guarantee for that current development, but also for future security against all the threats that are coming against us, including and not limited to the climate change crisis. I have had the pleasure and the privilege of attending the previous conversations on TB and PPPR, the Pandemic Preparedness, Prevention, Preparedness, and Response. And it is clear that universal health coverage, from those discussions themselves, is clearly the foundation for the achievement of a safer world and for achievement for health for all, including meeting the targets that are set for TB. UHC is needed. We have seen that many people do not have access, and access is increasing at the cost of people's wealth. UHC is not for the rich countries. It is most needed for those who are most vulnerable. They are the ones who need UHC most. Thank you. Before giving the floor to the panelists, I would like to take you through a UN ICT Lesson 101. Before giving, I would like to inform the participants that those wishing to speak during the interactive discussion are kindly requested to press the button located at the base of the microphone in order to be placed on the list of speakers. The representatives of the Secretariat will walk around the room to ascertain the organizations wishing to speak. So please feel free to write your organization and your name on this piece of paper. Those seated in the gallery should approach the attendant in their section. Once the name of your organization has been added to the list of requests to speak, please deactivate your microphone. When the moderator invites your organization, that's myself, to take the floor, please press the microphone once, not twice, not thrice. The green light on your microphone will guide the technician to activate your microphone. And once the light on your microphone turns red, indicating that your microphone has been activated, you may proceed to make your intervention. Participants may indicate their wish to speak starting now, so that the Secretariat can locate you so that we keep the list running. But we will only ask the participants to take the floor after we've heard from the panelists. We shall now turn to a discussion with the panelists, and thereafter, the floor will be open for comments. So, I am going to ask each of my panelists to take a maximum of 4 minutes. We appreciate if you can take less, but not more than 4 minutes. We agree. Good. We are all nodding, so we agree. I would therefore like to invite Emilia Saiz-Carracedo to comment on the following question. What really do governments need to commit to ensure equitable representation in decision-making processes so that policy is people-centered, gender and disability responsive, and meets the health needs of all throughout the life course? Your 4 minutes starts now.
Thank you very much, Chair, and thank you for this contagious passion that you have opened this discussion with. Now, there is a short answer and a longer answer to that question. The short answer is they need to involve all spheres of government. If they don't involve all spheres of government, and in particular those that are closer to the people, we will not achieve anything. We will certainly not make it community-based, and we will be doing business as usual. And allow me to say, over the 2 days that we have been discussing here in the different stakeholders hearing, the narrative seems to be all right. But I'm not sure that the funding or the legal frameworks are going to follow. And those will need to follow if we want to change anything. And so I think we have here this agenda can really change the world, this action agenda. But we will need to undertake some concrete steps. And one of the concrete steps that we feel we should undertake is changing the political leadership, bringing it to the local level, localizing Linking also the health care to the local service provision, universal local service provision to water, to housing, to public space, to clean energy is very, very important. And if we don't link these agendas, we will not make it. We will need to shift the lens towards a commons approach of health delivery and understand health broader than healthcare. We will need to take care of the carers as well and focus on gender equality, put a special focus on women's rights, human rights, to make a true difference. If we don't do this, I am afraid we will not be meeting the goals that we have set for ourselves. We will not meet universal health coverage, but we'll also not meet the Sustainable Development Goals, and we will be impeding as well a strong common agenda. The system that we are working with right now is a system that is based on inequality and where inequality is acceptable. And I'm talking about inequality not from a global perspective only and between countries, but also within countries. And this is why the local government's approach, the territorial approach, is so critical. So from our perspective, care at the center, linking the SDGs agenda with the healthcare agenda, universal health coverage as a critical articulator around human rights and local service provision, a commons approach, a gender equality approach. I'll stop there, Chair. Thank you very much for your attention.
Thank you. Thank you very much. Thank you for your contributions and the passion in them, and also sparing a few seconds. I would now like to ask Nupur Lalvani, Founder Director, Blue Circle Diabetes Foundation, what are the practical ways to ensure social participation, community engagement, and a multi-stakeholder approach in health, for example, through laws and policy frameworks, governance structures, and any other thing that you may have in mind to share with us?
Thank you for the question, Chair. Social participation and community engagement are critical to ensuring equity in health so that no one is left behind. How can governments address the needs of people if they are not talking to them about their health and healthcare services? Let me suggest 3 practical ways to foster social participation in health. First, governments can foster social participation by creating formal spaces where people can engage, talk, inform, and influence all phases of policy making, delivery of services, and evaluation of health programs. This can be done through consultations with people and consultations with all stakeholders across civil society and communities. And we know this can be done because here at the Civil Society Engagement Mechanism for UHC 2030, we have organized consultations in 40 countries in the last 2 years alone, where civil society and communities came together, shared their experiences with regards to access to health services, identifying gaps, and ways to address them. What we need is more governments to do the same thing. The whole process has to be participatory, inclusive, and very transparent. The second thing is that governments should put in place legal frameworks to institutionalize social participation and the empowerment of people, communities, and civil society to participate in and influence decision-making processes with regards to health. In many countries, legal barriers come in the way of certain communities, such as migrants, people living with HIV, mental health conditions, people with disabilities, ethnic minorities, indigenous people, to not only participate in health-related decisions, but also to access basic health care. There should be laws to mandate participatory mechanisms at all levels, from the village to the national level as well as the global level. At the national level, we've seen some examples like Thailand demonstrate how civil society, researchers, and governments can all come together in a participatory manner and work on UHC design and implementation. We need to evaluate these models to know that they've worked. At the global level, we've also seen efforts to push for institutionalizing social participation. For instance, the SDG targets 16.7, the Astana Declaration that calls for building and sustaining primary health care, which, as we all know, is the cornerstone of sustainable health systems for UHC, as well as the 2019 Political Declaration on UHC. All of these include specific mentions of social participation. Recently, in 2021, the Civil Society Engagement Mechanism for UHC 2030 supported the development of the WHO Handbook on Social Participation. These are all important steps forward, but we need more political leadership and will. Lastly, it's not enough for the government to create spaces for social participation. They also need to provide finances and other resources to enable all stakeholders, particularly those from resource-constrained and marginalized communities, to participate in decision-making processes for health. This requires resources like interpretation, preparation, orientation, support for travel, food, to ensure it's not just a tokenistic measure or a unidimensional measure and sharing of views, but an active engagement, and that accountability extends in multiple directions. Thank you.
Thank you very much, Nupur, for those remarks. And now I would like to come to Mahmoud Al-Hamoudi and ask you to comment on the issue of COVID-19. During COVID-19, health systems were unable to maintain essential health services. What do you see as the main causes for this, and what do we need to do differently in the area of policy, planning, budgeting, to progress UHC and health security agendas going forward so we don't have a repeat?
Thank you so much, Dr. Gitinji, and hello everyone. COVID-19 definitely reminded us of a simple but very powerful fact. Access to healthcare is a human right, and universal health coverage is at the core of the fulfillment of this right, where quality, resilient, and responsive health systems are equitably accessible to all. Although some advancement has been made on the UHC agenda, and COVID-19 showed us that the work on UHC remains in progress. The COVID-19 pandemic put us further back off track, impacting socio-economical determinants of UHC, but also interrupting the continuity of services. The world must now double health coverage up until 2030 in order to achieve the promise of health for all by 2030. COVID-19 reminded us that achieving UHC and health security rely on inclusive and resilient health systems as the basis, that are intersectional and intersectoral in their planning and design, and that are underpinned by resilient building blocks of health systems. Therefore, what can we do differently? 4 main things. 1, we need to invest in primary healthcare as the driver for UHC. Primary healthcare is the most efficient and cost-effective way to achieve UHC around the globe, with youth as important partners in achieving and maintaining PHC in all communities. Political commitments must acknowledge PHC as a central component of health systems, and that it should receive a fair share of the total healthcare investment. 2, adopt an interprofessional approach in the development of PHC services, ensuring appropriate planning, education, and employment of the workforce. Now, the second thing to do differently is facilitating and driving the digital transformation of health systems. Digital technologies have the potential to revolutionize healthcare delivery, promote health, prevent disease, expand coverage, and ensure the accessibility of healthcare to remote and marginalized settings. However, sustainable investment and coordinated planning is required. It is also crucial for member states to acknowledge and utilize the digital-first competencies of the young health and care workforce to optimize the design and implementation of digital health interventions. By prioritizing sustainable, equitable, and effective digital health systems, we can contribute to the achievement of UHC and health security and the improvement of health outcomes for all. The third thing we need to do differently is investing in the young workforce as a cornerstone for achieving UHC. The workforce was exposed during COVID. There can be no healthcare without the health and care workforce. As such, achieving UHC can only be pushed forth by investing in the preparedness and decent work of the health and care workforce across the globe. Ensuring decent work, including safe working conditions, equipped facilities, as well as fair remuneration for youth and young workers, while also eliminating discriminatory and ensuring gender and age equity in the full spectrum of the workforce are essential. The last thing that we need to do differently is ensuring population coverage for the true universality of health, universal health coverage. Population coverage is at the essence of UHC and must be prioritized for coverage to be truly universal. This necessitates that people are put at the center of policy design and implementation, and that the needs of all members of a community, including marginalized populations, such as migrants, refugees, youth, and gender minorities, are taken into consideration. Only by prioritizing population coverage we can work towards a more equitable and inclusive healthcare system for all. Finally, in addressing these action priorities and planning the road to UHC, we must call on all country leaders to deliver on their political commitments on UHC and translate them into actions, into concrete and time-bound national action plans underpinned by a whole-of-government approach and guided by a meaningful whole-of-society approach.
Thank you very much. Thank you. And now it's my pleasure to ask Mana Cunningham to comment on a related issue. So, Mana, COVID-19 exposed many of the inequalities that already exist within countries and also between countries. Effective change will require the recognition of structural and systemic barriers, including those related to gender and racial discrimination, among others. Can you share some potential interventions that the health sector could undertake to address these barriers and improve health outcomes for the most vulnerable? Over to you.
Thank you, Naxa. Also, Tralam Kulatara Maikisna. I greet you in the language of my people, the Miskito indigenous peoples from Nicaragua. And I greet you from the Fund for Development of Indigenous Peoples of Latin America and the Caribbean. In 1972, when I graduated as the first indigenous doctor in my community, I went back home. I realized when I began to work in the only small hospital that covered more than 100 communities, that I did not learn anything about traditional medicine, about indigenous diseases, and I had to coordinate to be able to ensure coverage with the knowledge holders, the traditional doctors from the communities, the midwives. And I began to understand the importance and the interrelation between health, land, natural resources, river, spirits, all of the things that are related with indigenous health system. During my almost 50 years of working as a medical doctor in indigenous communities, I have seen a lot of good practices. And the first type of practices are related with what indigenous peoples are doing. Indigenous, in each one of the communities, there are traditional healers. And they are the ones that attend whoever gets sick in the communities, but they also prevent from disease. So it's a holistic medicine. Some of these experiences is what we saw during COVID. The second type of good practices are, I have seen governments changing legislation, constitutional rights, recognizing intercultural health, and also adapting some of these traditional healing systems into their hospitals and into the health system. My experience in the autonomous region in Nicaragua has proven that we are now even preparing our own intercultural doctors in our universities. And we have expanded health coverage to all of these communities that where I come from. But I have also seen good practices at the regional level. The relation with the Pan American Health Organization, the promotion of resolutions at that level to educate governments, to advocate, to change the health system in government has been some of the good measures. One, for example, in FILAC, we are working with the private NGOs on diabetes, but at the same time, we are involving the indigenous communities. So what I would like to see in the new recommendations, first, the recognition of indigenous people's health system as a health system that if it's complemented with if it's complemented with the public health sector, we can really reach coverage. So that would help not only to improve the life of indigenous communities, but also to secure resources, forests, water systems that are interrelated. Thank you.
Wow. Thank you very much. And, appreciate our panel for keeping time so that they have reserved time for us to comment. So please, a big hand for the panel for keeping time. Thank you very much. Thank you. We'll now go straight to the floor. I will not repeat the instructions on the mics because I would hope that you're supporting each other on that logistic. So I would like to go straight to ask people to speak from the floor. We'll start off with Waki Health. Will be followed by Association Internationale de la Mutuelle, and then Trinidad and Tobago, NCD Alliance. So, Waki Health, please.
Thank you, Chair. Chair. So I am Smita Sadashivan from the Civil Society Engagement Mechanism for UHC 2030 and in partnership with Waki Health. And my statement is on health financing under UHC 2030. Health financing, the COVID-19 pandemic has demonstrated how rapidly weakness in our health systems impact our health, economy, social cohesion, and our trust in institutions, vulnerable populations being the worst affected. Achieving universal health coverage will lay the foundations for healthy people and societies, make countries more resilient to emerging and future shocks. To reach universal health coverage, governments must increase domestic public investment for health while prioritizing primary health care complying universal accessibility standards as a cost-effective investment and an approach that will contribute to greater equity in access to health services. Within a PHC framework, particular attention should be given to health and care workforce, including community health workers that is well-resourced, trained, protected, and institutionalizing the participation of communities in health decision-making processes. Governments must also develop and implement comprehensive, equitable health financing policies that reach the most vulnerable communities. Health financing policies should both expand quality health coverage and improve affordability for vulnerable groups. This means removing out-of-pocket payments such as user fees and providing nutrition, rehabilitation, palliative care, assistive devices, etc., at least for vulnerable populations and at the doorsteps as much as possible. Given the current economic outlook and macro-fiscal context, it is critical to provide greater support to resource-constrained countries by increasing ODA for health and unlocking new financing through the allocations of special drawing rights and debit relief measures. The international community must accelerate efforts to drive an urgent transformation of the global financial architecture to complement domestic resource mobilization in lower-income countries. Thank you very much.
Thank you. Next, I would like to ask Association Internationale de la Mutuelle.
Merci, Monsieur le Président. Votre Excellence, Mesdames et Messieurs, j'interviens en tant que président de la Mutualité française au nom de l'Association internationale de la mutualité. Acteur de la protection sociale, de la santé universelle, riche d'un engagement de plus d'un siècle par et pour les citoyens et les citoyennes sur les questions de santé, nous sommes convaincus de l'efficacité de la solidarité universelle en santé. L'Association internationale de la mutualité fédère, membre de l'UHC 2030, fédère plusieurs centaines de mutuelles en Europe, en Afrique, en Amérique du Sud, au Moyen-Orient. Les mutuelles santé sont des sociétés de personnes ancrées dans les communautés, participant du mouvement social. Elles favorisent l'accès effectif à la pleine santé en assurant le financement des soins individuels en santé de manière solidaire et collective, non lucrative et démocratique, et en réalisant des actions de prévention et de promotion de la santé auprès des populations dans les territoires. Forts de nos valeurs et de notre histoire, nous appelons les États à faire le constat que seule la solidarité et la non-lucrativité sont en capacité de donner accès au plus grand nombre à la protection en santé et que les mutuelles répondent pleinement à ces critères. Nous appelons également les États et les organisations internationales à prendre en compte, en articulation avec les mécanismes nationaux de protection sociale, les mutuelles comme mode de couverture et de partage des risques sociaux. Considérant la déclaration politique de 2019, dont nous soutenons pleinement les appels pour les financements internationaux et la prise en compte de la société civile, considérant également l'adoption récente de la résolution des Nations Unies pour la promotion de l'économie sociale et solidaire au service du développement durable, mesdames et messieurs, Votre Excellence, nous plaidons pour la reconnaissance du mouvement mutualiste et son rôle dans l'atteinte de la couverture sanitaire universelle. J'ai dit.
This is a reminder, both speakers from the floor have gone above the 2 minutes. Remember, every extra second you spend is a second taken away from another voice. So just try and keep to the time so that we have as many voices as possible. Next is Trinidad and Tobago NCD Alliance and the Healthy Caribbean Coalition. There are 2 minutes.
Thank you, Chair. I'm making this intervention on behalf of the Trinidad and Tobago NCD Alliance, an alliance of 13 NCD-related civil society organizations, and the Healthy Caribbean Coalition, which is the regional alliance of over 60 Caribbean countries. These CSOs are, in fact, located in small island development states, which, as you know, have their challenges. But in addition, the Caribbean states have an unenviable position of having some of the highest prevalence rates for NCDs and their risk factors. The 2019 coronavirus pandemic brought into sharp focus the need to accelerate action on NCDs, and it also highlighted for us the need for more strategic partnerships between the government and CSOs for health service delivery. We support the advocacy priorities of the Global NCD Alliance with these following comments. One, when we are urging investment, we ask that we remind member states that there's an opportunity to leverage funds from the Loss and Damage Fund created through COP and from the much-anticipated Bridgetown Initiative. Acceleration. As we accelerate, we must continue to focus on prevention of NCDs and urge that there be now an introduction of integration of services of that package of priorities identified by the countries. When engaging people-centered UHC, we must require governments to set up participatory mechanisms for this that includes a wide range of civil society organizations, people living with, unaffected by, and taking care of NCDs, youth and other vulnerable populations. TTNCDA, that is our Trinidad and Tobago NCD Alliance, and the Healthy Caribbean Coalition highlight the need for 2 enabling priorities. 1, enhanced communication. We need to build on the experience that was gained during COVID to strengthen communication strategies and mechanisms for provision of timely information to the population as well as to policymakers. And we must also have capacity building for accountability. We call on international partners to increase capacity of CSOs to understand the interrelationship of the commitments for UHC, NCD, and all relevant health-related issues, and to use integrated accountability frameworks.
And I now call upon the representative of Women Deliver. and after that, we'll hear from Brazil. Women Deliver?
Thank you, Chair. Women Deliver is a member of the Alliance for Gender Equality in UHC, a global group of over 60 civil society organizations that actively engage to ensure gender-responsive UHC. We align with the UHC 2030 Action Agenda, and we urge member states to support the following priorities. Fully deliver on all commitments to gender equality and equity, the human rights of women and girls, and sexual and reproductive health and rights made in the 2019 UHC Political Declaration. Design, implement, and finance gender transformative UHC that reaches the furthest behind. Commit to and act on delivering comprehensive SRH services in the UHC Essential Package of Services. These services address needs across the life course, including contraceptive services, maternal and newborn care, safe abortion, treatment for HIV/AIDS and cervical cancer, as well as comprehensive sexuality education, which is crucial to youth-friendly services and information both in and out of school. Engage women, girls, and gender-diverse people meaningfully in all phases of UHC. Ensure national health workforce plans are designed and operationalized to achieve gender equality in health. Strengthen recruitment and retention of health workers, the majority of whom are women. Undertake gender budgeting at all levels to inform budget allocations that support gender equality in healthcare systems and services, and ensure accountability and transparency in all action, bolstered by the collection, analysis, and use of disaggregated data. Lastly, my organization is called Women Deliver, but today I'm imploring governments, deliver for all women and girls. Deliver the health services they are entitled to as a fundamental right, and for women health workers. Thank you, Chair.
Thank you. Thank you. Next, Brazil. I now give the floor to the representative from Brazil.
Thank you, Mr. Chair. I would like to share the recent experience in Brazil. We are the country that has more than 30 years experience in universal health system, fully financed by the state. And this is the guarantee by law in our federal constitution. No government gives this for the citizen in Brasilia. It's a civil society rights movement that guarantee this. But we saw in Brazil with this, the recent government that Brazil had, I'm part of the new government, that just one government can put everything lost that we conquered for all the more than 30 years in Brazil. So I think we call that the declaration needs to be very clear, the commitment with the parliamentarians. I saw in these 2 days here, some of them, very few, and this is very important because parliamentary has the power to guarantee the law for the citizen. And we need to guarantee that for the country that already has this right, that this continue to do that. And for that one that still don't have, we need to fight for them. So we need that the parliamentary will be very clear in the declaration, and we need you to walk with us, because together we can guarantee the health, the right for health for everyone. But we need to do this together. Thank you very much.
Thank you. And now I give the floor to the representative of the International Federation of Pharmaceutical Manufacturers Association. IFPMA.
Excellencies and distinguished participants, the International Federation of Pharmaceutical Manufacturers and Associations, the IFPMA, would like to thank you for convening these multi-stakeholder hearings. COVID-19 has highlighted the link between UHC and global health security, and brought broad recognition that chronic conditions and pandemics constitute a perfect storm that requires building strong and resilient health systems and increasing health equity. Lessons from the pandemic emphasize the critical role of primary health care, which should include life course approaches to prevention, including vaccination, health promotion, screening, diagnosis, treatment, surveillance, and follow-up. This can only be sustained with sufficient domestic financing. Achieving SDG 3 requires investing more and investing better, as Dr. Tedros said earlier, on effective interventions toward UHC. While UHC is the primary responsibility of governments, success relies on combined efforts of all stakeholders. As a partner of the UHC 2030 movement, the IFPMA and its members reinforce the private sector's commitments to achieving UHC and fully support the UHC 2030 Action Agenda and the UHC 2030 Private Sector Constituency Statement, which outline key principles to guide collective action towards UHC. The innovative biopharmaceutical industry is committed to scaling up our contributions to UHC. We acknowledge our role in helping to improve access to quality, affordable vaccines, medicines, and healthcare for all via innovative approaches and partnerships. Sustained political support and effective multi-sectoral mobilization will be needed for countries to properly resource and protect health and care workers and strengthen their systems as the foundation of UHC. Thank you very much.
I would now like to give the floor to the representative from the Global Fund to fight HIV, TB, and malaria.
Thanks, Mr. Chair, for opportunity to make a statement on behalf of the Global Fund to fight HIV, TB, and malaria. The Global Fund plays a central role in accelerating progress toward UHC in different ways. First, to accelerate progress toward SDG 3, targeting to end HIV, TB, malaria as a public health threats, which is a critical part of achieving UHC. Secondly, through long-term investment to strengthen system for health, including community health. The Global Fund is now the largest multilateral provider of funding, providing more than $1 billion a year to support a resilient and sustainable system. We support health system in over 120 low and middle income countries so that they should be able to fight the pandemic of today, that is HIV, TB, and malaria, and detect and prevent, respond to outbreaks of tomorrow. Thirdly, through greater engagement and ensuring leadership of community and intensified focus on tackling health inequality, human rights barrier, and gender inequality, Global Fund support the building blocks of the strong UHC. We believe the health and care worker is essential for ensuring healthy people, society, and economy. The Global Fund is well placed in position to support countries to extend reach to vulnerable and marginalized groups who have greater needs and increasing support. Lastly, the Global Fund believes the 3 UNHL level meeting this year in September provide the opportunity to foster greater integration effort to end the major pandemic of today, like TB, to enhance PPR and make progress toward UHC. Thank you.
Thank you. Thank you. I would now like to give the floor to the representative from Indonesia. And after that, Last Mile Health.
Thank you, Chair. As a country of 275 million population, we understand well how universal health coverage is one of the determinant factors in the success of achieving sustainable development. The implementation of UHC in Indonesia has been done, among others, through its National Health and Social Protection Program, Badan Penyelenggara Jaminan Sosial, established in 2014. Since its establishment 8 years ago, the program has covered more than 86% of Indonesia's population, accounting for more than 241 million people. To contribute in the discussion today, allow me to share 3 points based on Indonesia's experience. First, in achieving greater implementation of UHC, synergies between national policies and operation to local engagements are needed. Second, as the backbone and frontliners of health sectors, efforts to strengthen the capacities and protection of the health workers are essential. 3, innovation is key. For Indonesia, the commitment to its UHC goes beyond its national realm. It goes higher to regional level, as reflected in its effort to support the implementation of ASEAN post-2015 Health Development Agenda, with UHC as one of its main priorities. Under Indonesia's chairmanship in ASEAN, we focus on concrete progress in the health sector through innovation. In this regard, we push for the digitalization of health sector as one of the key drivers to strengthen UHC. In closing, Indonesia stands committed to contribute to our collective efforts to pushing forward for greater implementation of UHC, including through adopting a concrete-oriented policy declaration. We look forward to collaborate with all stakeholders and committed to lend our full support to the co-facilitators, the permanent representative of Thailand and the permanent representative of Guyana in this process. I thank you, Chair.
Thank you, thank you. And now I give the floor to Last Mile Health. After that, Foundation Húsped.
Thank you, Chair. In alignment with the Monrovia Call to Action, resulting from the 3rd International Community Health Workers Symposium in March of 2023, Last Mile Health calls on the highest levels of leadership, including the United Nations system, heads of state, ministers of health, ministers of finance, and other line ministries, bilateral and multilateral partners, civil society, and the private sector to fund, scale, and strengthen community health programs as an integral part of primary health care for the realization of universal health coverage. In solidarity with other calls to support frontline health workers, community health workers deliver primary health care, improve health outcomes, and save lives. Community health is the equity arm of primary health care. Community health workers are leaders in providing an integrated package of services, including in emerging areas like non-communicable diseases and mental health. Investing in a professional community health workforce can produce a 10-to-1 return on every dollar invested as a result of healthier populations, increased productivity, and job creation, in particular for women. Addressing the health workforce challenges is essential for progress towards all health-related sustainable development goals, universal health coverage, pandemic preparedness and response, and reducing the impacts of climate change. Thank you.
And for sparing us 28 seconds there, thank you. I now yield the floor to Fundación Húsped, followed by World Obesity Federation.
I am presenting this statement as the Executive Director of Fundación Huésped, an organization which since 1989 has been working for the rights of people living with HIV and populations at higher risk of HIV. Likewise, we are members of a group of organizations from the Global South, which within the framework of the Sphere Collective are working to coordinate actions to promote the effective participation of communities in promoting universal health coverage. For us, working for the sexual health of community means working with communities to promote their participation. This high-level meeting is an opportunity to identify progress achieved and pending agendas with the states on the way to the 2030 goals, as well as to reflect on how to attain these goals. The participation of the most vulnerable populations, trans people, sex workers, incarcerated people, the LGBTI community requires concrete efforts to build spaces for dialogue, considering their needs and ensuring effective listening. These spaces must include their voices and be open to integrate their demands. We need to reduce discrimination barriers, and listening to the people facing them is the only possible channel. Thank you very much.
For sparing us further time, and now we yield the floor to the representative of the World Obesity Federation.
Honorable President and Chairs, distinguished delegates, I represent the World Obesity Federation with members in more than 100 countries. I also personally represent lived experience of NCDs. By 2035, the cost of continued inaction on obesity could rise to $4.2 trillion per year, and the rising obesity prevalence continues to be a major barrier to meeting most global health targets, including pandemic preparedness. With UHC recognized within new WHO recommendations on obesity, it is more critical than ever that we ensure health systems are equipped to address obesity and leave no one behind. Following this high-level meeting, how will governments rise to this challenge and ensure that universal health coverage includes delivery of integrated, non-stigmatizing obesity care for all who want it, and promote healthy environments in which are accessible to all? Thank you.
And thank you for giving us back some time. The floor now is for T1 International, and that's going to be followed up by Dominican Republic representative.
Special consideration is warranted for individuals living with chronic health conditions who have needs beyond primary health care. The needs of these individuals are often not recognized in healthcare systems, and they face no or limited choice when it comes to treatment options. For example, individuals living with type 1 diabetes, like myself, may lack reliable access to affordable insulin and be limited in their choice of insulin by their healthcare system. This flies in the face of the right to the enjoyment of the highest attainable standard of physical and mental health, as it often prohibits individuals from taking advantage of new advancements and technologies in diabetes care that would allow them greater flexibility and capacity to pursue life opportunities beyond survival. Across the globe, patients are spending an unsustainable amount for the medicine and supplies they need to simply stay alive. In many parts of the world, people are forced to pay as much as 40% or more of their total income on the bare minimum to manage their diabetes. In 2022, T1 International, an organization dedicated to equitable access to medication and supplies for diabetics across the globe, conducted its most recent out-of-pocket cost survey, looking at the costs to individuals worldwide of insulin and other essential diabetes supplies. Analysis of this data is still underway and will build off of 2020 survey results, which found that 1 out of every 4 respondents reported having underused their insulin at least once within the last year due to high cost, and 63.2% of participants reported disruption of insulin supplies, and 25.3% reported an increase of insulin prices related to the COVID-19 pandemic. Transparent pricing and pharmaceutical and industry accountability to fair and affordable pricing of medications is paramount. Governments and high-level organizations collectively need to ensure that pharmaceutical companies and device manufacturers are held to profit maximums that ensure access to essential drugs and devices for all people. Thank you.
Dominican Republic, the floor is now yours.
Muchas gracias a los panelistas por compartir sus visiones y recomendaciones. La cobertura universal de salud encarna el principio de que todas las personas, independiente de su origen socioeconómico, deben tener acceso a servicios de salud esenciales. Al implementar la cobertura universal de salud, las sociedades pueden abordar las evidentes disparidades en el acceso y los resultados de la atención médica y promover no solo el bienestar físico y mental, sino también el desarrollo social y económico. La pandemia del COVID-19, como han externado anteriormente, ha puesto en evidencia cómo la seguridad sanitaria y la cobertura universal de salud están entrelazadas. La cobertura sanitaria de salud mejora los resultados de salud al facilitar la detención temprana, la prevención y el tratamiento de enfermedades, salvando vidas. Los altos costos médicos han llevado a la gente a la pobreza y la cobertura universal de salud protege a las personas y familias del impacto devastador de los altos costos de los medicamentos y servicios, protegiéndoles de la inestabilidad financiera y asegurando que la atención médica sea un derecho universal y no un privilegio. Es un catalizador para reducir la desigualdad y fomentar la cohesión social. Se debe también establecer un marco para la financiación, la gobernanza y la prestación de servicios sanitarios. Como mencionado por los panelistas y por otros, la inversión adecuada en infraestructura sanitaria, la mano de obra y también la tecnología se convierte en una prioridad. En conclusión, la cobertura sanitaria universal sirve como un impulsor vital para acelerar la salud para todos, pero igualmente incorpora los principios de equidad, de justicia social y de derechos humanos, al garantizar que nadie se quede atrás en el acceso a servicios de salud esenciales. Al implementar la cobertura sanitaria universal,
las sociedades pueden promover poblaciones más saludables, reducir las desigualdades, fomentar el desarrollo sostenible y crear un futuro mejor para todos. Muchas gracias.
Thank you, thank you. And now the floor is for Mexico Sociedad Civil. The floor is yours. Followed by Self-Care Trailblazer Group.
I am a mother adult with multiple sclerosis. I know the struggles of many parents of children with NCDs and rare diseases, unable to meet the regular expenses and expensive medicines, rehabilitation services like physiotherapy, vision therapy, counseling, day-to-day care services like bladder management, bed sore management, protection, treatment from other infections that chase them always. Care services should be part of health services. We need trained caregivers to be included. Thank you.
Thank you, thank you. And now the floor, from the last contribution from the floor, we yield the floor to Self-Care Trailblazer Group. And after that, I'm going to ask each of the panelists to make a 1-minute remark in response. So the floor is yours, Self-Care Trailblazer Group, for 2 minutes.
Thank you, Chair. I represent the Self-Care Trailblazer Group, a global coalition working to advance the landscape of self-care for sexual and reproductive health and rights. As defined by WHO, self-care is the ability to manage your own health with or without the support of a provider, including use of HIV self-testing, self-managed contraception and medication abortion, and digital tools for self-monitoring, to name a few. It is an undeniable aspect of individual health and behavior and an important and growing component of health systems. As such, the political declaration on UHC must explicitly and directly acknowledge and champion the vital role of self-care. Self-care aligns with each of the 8 action areas and should be mainstream within the UHC actions at the global and national levels. While it's not a replacement for the health system, self-care equips individuals and communities with more options to access health services. This is especially important for vulnerable populations, including women, girls, transgender individuals, youth, rural population, those in humanitarian settings, and stigmatized groups such as people living with HIV and sex workers. We call on member states to institutionalize self-care within their national health systems through supportive policies, program financing, and regulations, by encouraging individuals and communities to act as informed agents for their own health and well-being through healthy lifestyle choices and self-managed disease prevention and control measures. Limited health resources can be used more efficiently and effectively. This can reduce the burden on health workers, health facilities, and government budgets, ensuring that resources are available to manage conditions that require the support of providers. Access to self-care is integral to reform health systems, with the understanding that it's not a substitute for a government's responsibility to provide quality services. By supporting individuals to care for their own health, UHC can be implemented more successfully, leading to better health outcomes and improved quality of life for all. Thank you.
And we have a last request from a member state, that's Argentina. So please, the representative for Argentina, you may take your 2 minutes now, and that will be the last contribution.
Muchas gracias, señor moderador, por darme la palabra. Celebramos una vez más la participación activa de las organizaciones de la sociedad civil en esta audiencia. La pandemia del COVID-19 puso a prueba la capacidad de respuesta, no solo de los sistemas de salud, sino de los sistemas de protección social en todo el mundo, transformándose rápidamente en una crisis socioeconómica, humanitaria, de seguridad y de los derechos humanos. En este sentido, reconocemos el valor de los debates actuales acerca de los progresos realizados hacia la cobertura sanitaria universal. Asimismo, destacamos las oportunidades que la pandemia puso de manifiesto, como el trabajo en red, las articulaciones intersectoriales y dentro del sistema de salud, la utilización de nuevas tecnologías de la información en la estrategia de salud digital, el seguimiento de casos y el control epidemiológico. En este sentido, la Argentina asumió la tarea de reorganizar el sistema de salud hacia la atención primaria, como base de la cobertura sanitaria universal, y de afianzar su gobernanza, priorizando líneas de acción estratégicas que pueden adaptarse a las particularidades de cada jurisdicción. De esta forma se procura asegurar el cuidado integral de la población a lo largo de todo su curso de vida en todo el territorio nacional, con la equidad y la solidaridad como pilares esenciales. La estrategia de atención primaria, como una herramienta eficaz para la promoción y el ejercicio efectivo del derecho a la salud, tiene como fundamentos garantizar la equidad en la atención, promover la accesibilidad de todas las personas a los servicios de salud, fortalecer el desarrollo de acciones dirigidas al cuidado integral, continuo, oportuno y de calidad de las personas y comunidades, promover el respeto de las singularidades culturales en el territorio, brindar a todas las personas iguales oportunidades para el acceso a un sistema de protección de salud de calidad, difundir información adecuada y veraz acerca de las cuestiones relacionadas con la salud y su cuidado, y finalmente, promover la participación activa de personas y comunidades en las decisiones relativas al cuidado de la salud a partir del consentimiento informado y de los derechos de los y las pacientes. Muchas gracias.
Mr. Gracious, thank you. Thank you very much. Now, of course, there maybe have been people who wanted to speak, but they didn't get a chance. So please, you're encouraged to post your statements on Indico so that they can also be considered. Or if you want to post a more comprehensive statement beyond the 2 minutes you made, please feel free to do so on Indico. I would now like to invite the panelists to make less than 1 minute, maybe 45 seconds of contribution. And I will start off with you, Emilia.
Well, thank you very much. It is clear there is no one-size-fits-all, but there are some critical pillars that are important for everyone. And from what we have heard, including communities, all communities in decision-making is extremely critical. And we will need to start at territorial level. We will need to make sure that we localize that response. And finally, no single country in the world has been able to respond adequately to COVID. Let us remember that. We have all failed. And we have failed also in solidarity. So those cannot be the models for the kind of universal health care that we are promoting. And finally, the link between this agenda, the universal health care agenda, the healthcare agenda, and the Sustainable Development Goals is very, very important. And working on SDG 3 also means working on SDG 8 on decent work and economic growth, but also on climate action, but also on human mobility, and also SDG 11 for sustainable cities. Thank you.
Thank you very much. Mahmoud, your 1 minute.
Well, I love analogies. While I was reflecting on the interventions, I could only think of UHC as a building. Delivering on this building is based on 6 core building blocks. 1 is comprehensive and quality service delivery. 2 is prepared and protected health workforce. 3 is open and responsive health information and research. 4 is accessible medicines and technologies. 5 is sustainable health financing. And 6, and most importantly, is strong leadership and governance. At the backbone of this building lies people. So this building can only rise up guided by human rights, by equity, by inclusion, and meaningful engagement. Let's build UHC together, for healthcare should be accessible to all people, regardless of their origin, of their socioeconomic status, migration status, physical condition, and identities. Let's not dream about health for all. Let's work together to make it a reality.
Thank you. And Mana, your 1 minute.
My minute, universal health system can only be we can only reach it if we include everybody. And I just want to highlight the health system models of indigenous peoples to be included in any health model if we really want to reach universal coverage. Thank you.
Thank you. And finally, Nupur,
It's our duty to remember why we are here today and who we are here for. As people living with NCDs and multiple health conditions, often we pay a catastrophic price in more ways than one. In India, my organization, Blue Circle Diabetes Foundation, was put in touch with an auto rickshaw driver whose 10-year-old daughter lives with type 1 diabetes. Upon talking to them, we realized the family does not have a fridge at home. So we supported them with a mini refrigerator to store their insulin, and we also helped them with diabetes education and medical supplies. We need to remember that these are the people that we are here for today, and they need a mechanism to voice their voices, and the government should be able to hear them clearly. Thank you.
Thank you very, very much. And now I would like to take this opportunity to thank the President of the General Assembly for the diversity on this panel. This has been a fantastic panel, and its balance and diversity and inclusion is commendable. So that's to the President of the General Assembly and all the organizers. Finally, I would like to remind participants that now the second panel, which is entitled From UHC Commitment to Actions and Accountability, is starting next. I thank you all for sparing your time to come here, and let us go forth in the spirit of Ubuntu. I am because you are. This panel is now closed, and I invite the panelists and the moderator for the second panel to take their seats on the podium.
Good afternoon. We'd like to start the second session. If everyone could please take your seats. Thank you, everyone. Welcome to our second and last session of these multi-stakeholder hearings. My name is Elisha Dangiorgio. I am the president and CEO of a US-based NGO called Global Health Council, and I will be moderating the session today. Session 2, from UHC Commitment to Actions and Accountability. I have to say, as a lifelong advocate, action and accountability, especially when said together, are two of my favorite words. So I think it's very fitting that we end our 1.5 days together with a session focused on turning commitments, often words on paper, to tangible results and change for real people. We know that this action for UHC commitments is going to require measurement, it's going to require multi-sectoral partnerships, and it's going to require money. And we know most importantly, as we move into these actions, we must all hold ourselves accountable for treating each person with equity, respect, and dignity. Today, this panel is going to talk about some of the pragmatic steps we can do to turn that commitment into action and accountability. Before I turn to our panelists, I am going to take a minute to do one more procedural note. If you did not submit or queue up in the last session to make a statement of intervention after we have gone through the panel, please press the button now on your microphone and fill out the white paper with your organization. We still have quite a few organizations from the last session that did not get to speak that are in the queue, as I understand it. And oh, you want them resent? Oh, okay. I'm sorry. I got confusing instructions. You need to resubmit. If you did not get put into the queue in the last session, please hit your microphone, write your name on your organization's name on the white paper, and an attendant will come around and collect those so that you may be put in the queue for 2-minute statements after our panelists have made their interventions. With that, I would like to introduce our panel. We are joined today by Ms. Sarah E. Nunez-Cerrón, Vice President of the IPU Advisory Group on Health, Dr. Vytenis Povilis Andriukaitis, who's the former European Commissioner for Health and Food Safety, UHC Movement Political Advisory Panel, and WHO Special Envoy for the European region, Ms. Olesia Struck, Senior Director, Group Sustainability of Royal Philips and representing the private sector constituency of UHC 2030, Dr. Lujan Al-Kodmani, President-elect of the World Medical Association, and Ms. Domisa Gacha, the founder of Success Capital Organization. We're going to hear from each panelist for 4 minutes. Please try and keep your interventions at 4 minutes, everyone. And I'm going to start first with Sarah E. Nunez to talk about government-sustained investment in health.
Thank you very much. Action area number 5 of the action agenda on universal health coverage from the UHC movement is precisely the reason why I'm here today. Why should governments and parliaments invest more, invest better in comprehensive national health plans with sustainable public financing? One thing we know for certain, and was a fundamental lesson after COVID, is that universal health coverage should be kept at the highest political agenda, and national budgets should be people-centered budgets. There is a saying that I have constantly heard from my dear co-chair of the UHC 2030 movement: true love is only shown in budget. If not, it's only political narrative. As parliamentarians, we have 4 legal responsibilities: legislation, oversight, budget allocation, and what I believe is definitely the most important, people's representation. Universal health coverage is key to ensuring that all people have access to the health services they need on an equal footing and without suffering financial hardship. As a Mexican parliamentarian and as vice president of the Interparliamentarian Union's Advisory Group on Health, I believe that it is very important to underline 2 very important aspects. The first one is related to legislation. We have to be absolutely sure that we are having health as a recognized human right, placed in our constitutions, placed in our legislations, guaranteed by institutions. But when talking about budget allocation, we have to recognize budget is the most important public policy instrument that parliamentarians have. And with this, I would have to stress, health is an investment, not a cost. And as parliamentarians, there is a huge responsibility that must be assumed. In October 2019, under the presidency of Gabriela Cuevas, the Interparliamentary Union adopted a resolution of UHC, achieving universal health coverage by 2030, the role of parliaments in ensuring the right to health that precisely underscores the unique contribution parliaments can make towards achieving universal health coverage by using their powers, legislate, adopt budgets, and determine spending priorities. Parliaments have the capacity to hold the government to account and to conduct advocacy and awareness raising. Overall, this resolution provides a roadmap to parliaments to move towards UHC. It highlights the importance of primary health care and people-centered health systems with a strong focus on women, children, and adolescent health as a key component of UHC. It also calls on parliaments to allocate adequate domestic resources and to ensure financial protection in order to reduce out-of-pocket payments for health services and to eliminate financial barriers that prevent access to health. What I'm about to mention might sound harsh, but why have I not heard that there should be a certain percentage of our budgets committed specifically to our health as citizens, just as it is when citizens are obliged to give a certain percentage of their income taxes. The IPU stands ready to provide support to national parliaments to build the necessary capacities to move towards universal health coverage. Thank you very much.
Thank you, Sarah E. It's been impressive to see the role of parliamentarians here at these multi-stakeholder hearings, and I think we'll all be reciting that phrase, true love comes in the budget. So thank you for that. Next, I'd like to turn to Dr. Andriukaitis to talk a little bit about what policymakers can do to reorient health systems for a primary healthcare approach.
Thank you. I couldn't agree more, and I see so passionate statement was done by Sarai. And of course, we all know very well, now it's time for all politicians to be political leaders in universal health coverage. No way. We need now in our family, like to say, new Greta Thunberg. It can raise those questions around the globe, and say political leadership. And it is our action number one in our action agenda, political leadership. And of course, first of all governments should implement collective responsibility to realize people's right to health and use their power to do so. Realizing health for all requires political will at every stage, at every level, and adequate resources backed by heads of states, social, financial, education, health ministers. Whole of government approach is needed, no doubts. And of course, it requires streamlining universal health coverage in national health policy frameworks, as well as broader priorities such as health security, social stability, climate, economy, and finance. Policymakers need to establish also a whole of society approach. We all are speaking about that. We need to include NGOs and all sectors, civil society sector, and institutionalize this into national action plans and into governance of health systems. This will ensure that policies respond to all people's health needs and improve their health, encourage trust in policies, and make health systems more transparent and more accountable. We all need that. And of course, second, we need policymakers to make sustainable investments in health systems and in particular, properly resource and protect health and care workers. I have a dream. I think we all have a dream. Like Martin Luther said, it would be good to achieve in 2030 minimum 5% of GDP invested into primary health care, minimum around the globe, and 3% of GDP to dedicate to prevention as ground globally. It would be really big progress in 2030 to see that where you have real power and real protection of people's rights. Of course, to support also, we need to support health workers, policy makers. They need to apply robust planning and financing to retain, expand, and protect the health and care workers. Leaders must recognize that we cannot address health crises, climate disasters, and humanitarian emergencies with a shortfall over the 10 million health care workers around the globe. Now we have 2023 and 2024, 30. Only 7 years. Can you imagine how can we work to achieve, to realize that healthcare worker shortages should be addressed? Of course, we need to see how can include gender equity in leadership role, closing the gender pay gap, and recognize and remunerate unpaid and underpaid health and care workers, including community health workers. It cannot be unrecognized that women currently make up 70% of the global health and care workforce, but only 25% of senior and leadership roles. It's a little bit shame around all the globe. We need to change it. Of course, lastly, policymakers must urgently commit to equity and to leaving no one behind. National health policy framework must address the health needs of vulnerable and disadvantaged groups throughout their life course. The primary health care approach is the most inclusive, equitable, cost-effective approach to achieve universal health coverage. Health systems that are centered around primary health care are linked to better health outcomes, improved equity, and increased protection from health emergencies. The political declaration that comes out of the high-level meeting on universal health coverage in September, what we need from policymakers and member states is for them to make accountable actionable commitment to achieve universal health coverage with a primary health care approach. It is our philosophy. Primary health care is a basic, and we need to see universal health coverage, no universal health coverage without primary health care. Thank you.
Thank you. Your passion is notable, even if you did go over your 4 minutes. It was well worth it. Thank you for, the reminder that we only have 7 years until 2030, I think is a sobering note for us to keep in mind as we talk about action and accountability. Next, I'd like to turn to Alessia Struck to talk with us a little bit about strengthening innovation, efficiencies, and partnership. Alessia?
Thank you, Chair. Good afternoon or good morning to those there online, excellencies, distinguished guests, colleagues, and friends. The private sector is committed to innovating to achieve universal health coverage on the road to health equity and to sustainable, environmentally sustainable healthcare. As the Chair mentioned, this session is about actions and accountability, so you can keep us accountable. I invite you to also to check our updated statements and example case studies of our commitments and what we have done since 2019 on this road to UHC. Quick recap, the private sector includes healthcare companies and entrepreneurs, private insurance and healthcare providers, to name a few. Our key capabilities are in supply, innovations, but also in investments, business models, job creation, and taking care of our employees. Since 2019, we collaborated a lot. Collaboration and innovations have grown. Multi-sectoral collaboration as well. It has grown exponentially. But it's not enough to scale. Let me give you an example of the work that was done and the key lessons learned and how it links to the action agenda that we also commit to as the proposed 8 points of action agenda on the UHC 2030. So an example, my company Royal Philips had an ambition to innovate for comprehensive primary health care, as we call it community life centers, as part of SDG partnership together with governments, NGOs, including primary healthcare workers, community health workers in Africa. It was a great journey. We have made impact in over 100 primary care clinics. But in order to move the needle towards UHC, we need hundreds of thousands primary care centers. As my predecessor, fellow panelist mentioned very passionately, primary care needs to be co-invested, co-designed, and co-innovated, including public, private sector, and civil society, and local ecosystem. So we've learned a lot, and therefore I would like to call 3 lessons that are also integrated in the action agenda. And we ask for the member states, as also my colleague Sarai Munoz-Serron mentioned from the IPU, to look into implementing this in the regulatory frameworks, in the plans and commitments, which will unlock the resources of the private sector contribution. First, we can partner faster at scale and across countries, as COVID showed. PPP models for primary care are complex. Instead, we need political leadership. When each country sets the goals, guardrails, budgets, and governance, other stakeholders will act with impact. Also, part of such partnership should be investable, because then the private sector can bring foreign direct investments and blended financing resources in. Second, we must ensure local ecosystem collaboration is there for new models of care. Example, the City Cancer Challenge by a dozen innovative pharmaceutical companies. The initiative supports cities around the world to improve access to quality, equitable cancer care by also ensuring local ownership. Third lesson learned, that we shall continue building trust and collaboration early in the process between public, private sector, and civil society, since we invite to co-design, co-create, and co-invest. Collaborative platforms like the Digital Connected Care Coalition help to do so. Example is Vodun initiative for federated and fair health infrastructure active across, for now, 9 African countries. The goal is creation of financial self-supporting, federating data space that can keep the data ownership with patients and curated by the health facilities. But also it will enable us to innovate new models of care. So in summary, we are committed to and accountable for being a critical partner on the road to UHC. And we ask for the governments and parliamentaries to create an enabling policy environment that recognizes and sustains innovation, co-investments, sustainability, supports constructive partnership, and allowing to share best practices and lessons learned. Thank you.
Thank you, Alessia, and thank you for reminding us how important a partner the private sector is in advancing this agenda. I just want to remind our panelists to please try and stick within your 4 minutes if you can. I know we're all passionate about this topic, but we want to make sure to have time to take statements from the floor as well. Next, I'd like to turn to Dr. Al-Qodmani to talk with us about the health workforce and how we can build and ensure a sufficient, competent, and compassionate workforce.
Thank you, moderator, distinguished delegates. As correctly highlighted by Mr. Povelas, we're actually still missing around 10 million health workers worldwide. But actually, did you know that there's an increasing rate of unemployment among young physicians and other work professions due to fragile healthcare systems? On behalf of the World Medical Association, which is a global organization, represents 10 million physicians worldwide from 115 countries, I'm honored to be with you here today to highlight some of the barriers, the challenges, as well as the opportunities to develop a competent and compassionate health workers or health workforce, which is one of the prerequisites for the achievements of UHC. First, lack of safe working environment, and this placed healthcare professionals under a great risk and immense work pressure. We urge the governments to provide an excellent and safe working environment and prioritize the health workers' conditions, including mental and psychological support. We also voice the concerns of health risk for health workers, for PPE, vaccines, and other forms of health protections and risk reductions that are insufficient, and emphasize the need for evidence-based IPC training in all healthcare settings. In addition, decent work conditions should also include fair, equal, timely, and consistent pay for all health workers. Second, according to World Health Organizations, up to 38% of health workers face physical violence at least once in their career. However, this percentage does not include all other forms of violence. We are constantly witnessing an increased rate of violence against health workers, all forms of violence, particularly during the COVID pandemic. And this violence includes co-worker violence, aggressive behavior by patients or family members, including physical and psychological violence, as well as intimidation and cyber harassments. That's why healthcare professionals need to be protected from work-related violence and harassment, particularly women and children and youth who are at risk of sexual exploitation, abuse, and harassment. We urgently call for government to prevent and eliminate such brutality by providing a safe working conditions and establishing zero-tolerance laws and legislations towards workplace violence. Third, lack of financial investments in the healthcare sector. We ask for increased health budgets at all levels to strengthen the health system infrastructure, to provide more job opportunities and equal access to good quality healthcare services for all. Fourth, lack of equal training and education opportunities. We are in great need for effective and accessible country-specific career progression guidelines, supervision, and mentoring and education programs for knowledge and skill development. Last, I would like to emphasize the importance of holistic primary healthcare system as essential tool to achieve UHC. We ask to be involved in national reforms, strengthening the PHC system, which include individualized care and essential public health services to enhance the capacity to address the social determinants of health and develop a strong referral system between PHC center and hospitals. I thank you. I'm on time.
Thank you so much, Dr. Al-Qadmani, and I can't go without saying that you cannot have a health system without healthcare workers, and that we often talk about striving to treat patients and users with respect and dignity. We don't talk enough about that when it comes to health workers, and that has got to be a part of the action and accountability in the UHC agenda, so thank you very much. Lastly, but not least, I'd like to turn to Ms. Domisha Gacha for an intervention talking about governance, measurement, and how we focus on those most often left behind. Dumi.
Thank you. As a part of the civil society engagement mechanism for UHC 2030, we have developed several tools to enable and strengthen the tracking on progress and on UHC, including Health for All and social participation toolkits, along with contributing to the state of UHC commitment reviews. These tools have not only opened doors for grassroots organizations, but have enabled conversations and solutions building where there are shortcomings. The challenging health landscape since 2019's political declaration on UHC reflects how commitments are not enough. Governments need to guarantee the right to health through legislation, policy, and investments anchored in leaving no one behind. Measuring progress demands for us to move beyond linear and normative monitoring and evaluation mechanisms as countries increasingly commit to UHC, whilst the UHC commitment reviews reflect little progress on implementation. Reporting on UHC remains a challenge. Data is limited, fragmented, and often excludes those in the margins. We need stronger reporting mechanisms that include civil society participation. Disaggregated data reporting on UHC will ensure no one is left behind in voluntary national reviews, national statistics reporting, Global Fund country coordinating mechanism infrastructure, national development planning, treaty bodies, and special procedures to ensure an intersectional, holistic approach to reviewing and addressing social determinants to UHC. These not only improve multi-stakeholder engagement, but also accelerate interventions and inclusion. Civil society-led consultations have shown that many of us are left behind. People on the move, including migrants, stateless and displaced persons, people with disabilities, people living with HIV, people with diverse sexual orientation, gender identity and or expression, people engaged in sex work, people who are intersex, indigenous, neurodivergent, ethnic minorities, people who are criminalized, people who are imprisoned, people living in poverty, and people living amidst humanitarian, climate, and conflict crises. More broadly, youth, women and girls who continue to face structural impediments to accessing health services and care. This includes experiences by Success Capital organization, where we have encountered several issues around community health, such as a mother based in Chukumuchu who can go full term without having seen a nurse or midwife because of poor infrastructure, planning, and resourcing, or denying a young Kalanga lesbian motherhood because of inadequate provisions for quality reproductive and mental health care, as it does not fit within what being queer looks like. Similarly, failing to address structural inequities to accessing health, including stigma, discrimination, harmful gender norms, non-recognition of care work, and gender-based violence. This reflects why social participation is needed at regional and country levels to accelerate implementation, track progress, and hold governments accountable for commitments made in sustainable development, human rights, and governance mechanisms. This can lead to equitable, non-discriminatory, participatory, gendered, and inclusive health programs, policies, and interventions, with UHC as an entry point for advancing integrated primary health care, health systems strengthening, pandemic preparedness, and health security. Accountability should center people who are most impacted. This includes health information, mechanisms for redress where harm is done, and meaningful resources for equitable participation of civil society and the most impacted communities. Thank you.
Thank you. Thank you, Dumi. I think that's a perfect note to end our panel discussion on, that health and well-being is so much more than what happens when you go to the doctor, that it's all about society's investment as a whole, in the whole person, and that to do that we have to be, as you said, working across sectors and involving and engaging meaningfully from the beginning and co-design people with lived experiences. So thank you so much. I am now going to start with statements and interventions from the floor. So I think we have been through this many times now, but just a reminder that I am going to call the organization's name, press the microphone one time, just once, and then when the red light comes on, you may speak. Please stick with 2 minutes. This is a little bit of an equity practice exercise for everyone, that if you have 2 minutes, the next person can have 2 minutes, but if you take more than your time, you're eating into other people who would like to make statements time. So let's try and be conscious that there are others who also want to speak. So we're going to start with FIND, followed by the World Heart Federation. So FIND.
Thank you. FIND works with a diverse set of partners to spur innovation and invest in the development, deployment of accurate, appropriate, affordable, accessible diagnostic technologies and tools for countries. Diagnostics are fundamental to building sustainable, resilient, equitable health systems. The COVID-19 pandemic has emphasized the crucial role of diagnostics in delivering health care. Yet diagnostics continues to suffer from low visibility and prioritization in the discourse on universal health coverage. FIND's experience over the past 2 decades has shown us that unless the gap in diagnostics provision is addressed and investment in diagnostics is expanded, the promise of UHC will not be achieved. It is critical for countries to deliver upon the commitments made in the 2019 Declaration of the High-Level Meeting on UHC, including coverage for all people with quality, safe, effective, affordable, essential diagnostics by 2030, eliminate financial barriers to access to diagnostics, promote equitable distribution of and increase access to diagnostics, and improve availability, affordability, and efficiency of diagnostics through better regulation. Further, to address unmet needs, we need to develop and deliver novel diagnostics and increase primary primary care level access to essential tests. Countries should promote investment in R&D for new diagnostics, develop national essential diagnostics lists, and strengthen regional manufacturing capacities to enable the delivery of testing services and technologies to everyone, everywhere, at any time. UHC won't be successful unless it is, one, built on strong, routine, and resilient primary healthcare systems, including access to safe and effective affording testing and surveillance, coordination across sectors, placing countries at the center, and include civil society and community engagement at all levels. Phew, thank you.
Thank you, Find. World Heart Federation, followed by Rehabilitation International. World Heart Federation.
Thank you, Chair and distinguished delegates. We at the World Heart Federation, and I'm joined here by members from the American College of Cardiology and the American Heart Association in the room, we note with disappointment that according to the latest report by the WHO Director General, the world is not currently on track to achieve the SDG targets. However, we feel strongly that a universal health coverage system that incorporates a few key strategic components could help us get much closer to the targets than our current trajectory. Circulatory diseases, including heart diseases, stroke, diabetes, and kidney diseases, are the #1 cause of death and disability worldwide, leading to more than 20 million deaths and 374 million healthy years of life lost every year, a significant toll. In the absence of UHC, the chronic nature of circulatory diseases has a catastrophic impact on a country's development and is responsible for the generational poverty experienced in many low and middle income countries. In fact, over 60% of people living with cardiovascular disease, stroke, incur catastrophic out-of-pocket expenditures in many LMCs each year. As witnessed during the COVID-19 pandemic, cardiovascular disease also has a devastating compounding impact on health when experienced alongside infectious diseases. Therefore, the World Heart Federation, supported by members of the Global Coalition in Circulatory Health, calls on member states to A, engage people with NCDs and circulatory conditions to keep UHC people-centered, accelerate progress towards universal health care through robust and well-financed primary health care systems based on the principles of quality, equity, accessibility, and affordability, ensure adequate and sustained financing for and availability of circulatory health services in the context of national UHC strategies, including for prevention, acute and chronic treatment, and rehabilitation, while additionally incorporating digital innovations in circulatory health. Include cost-effective circulatory health interventions that also address their risk factors into national UHC packages of essential interventions to be delivered at primary health care level, drawing on examples from Appendix 3 of the WHO Global NCD Action Plan and the Heart's Technical Package. 90% of essential interventions for UHC can be delivered through primary health care. We urge member states to embrace health as an investment, and we look forward to supporting you in your endeavors. Thank you.
Thank you. Rehabilitation International.
Thank you very much, Chair. Rehabilitation International is an independent organization with members in more than 100 states in the world. It is committed to the implementation of the UN Convention of the Rights of Persons with Disability and advocates for strengthening rehabilitation across sectors, including health, labor, education, and all other aspects of life. For the implementation of universal health coverage and to make sure that persons with disabilities can profit from UHC services, it is crucial to ensure and to promote, first, that persons with disability have unrestricted access to health services according to the principles of UHC. Second, that barriers for access to health and rehabilitation services will be removed, including physical barriers, financial barriers, and barriers occurring from the lack of awareness and the lack of expertise. Third, that health professionals are appropriately trained in the special needs of persons with disabilities, including the principle of shared decision-making. 4, that high-quality rehabilitation services and assistive technology are available for all persons in need, including persons with disability and without financial hardship. 5, that rehabilitation services and assistive technology are appropriately equipped and financially resourced, as well as designed to meet the special needs of persons with disabilities. 6, that rehabilitation services at primary care level and in the communities, as well as the number of rehabilitation professionals and community-based rehabilitation workers is expanded. 7, that research is performed on the implementation of rehabilitation and assistive technology in health systems, the access for persons with disabilities to health care, including rehabilitation and assistive technology, the needs and effects of rehabilitation interventions and assistive technology provision. Thank you very much.
Thank you. Thank you so much. I'd like to now ask for an intervention from Kazakhstan, followed by WIMOS. Ambassador.
Уважаемая госпожа модератор, благодарю за предоставленное слово. Хотел бы выразить признательность уважаемым панелистам за их интересные и полезные выступления, а также, пользуясь случаем, поблагодарить уважаемых ко-фасилитаторов делегации Таиланда и Гайаны за их важную работу по подготовке к заседанию высокого уровня по всеобщему охвату услугами здравоохранения в сентябре. От имени делегации Казахстана хочу отметить, что политическая декларация, принятая в ходе прошлого заседания по ВОУЗ в 2019 году, подтверждает, что первичная медико-санитарная помощь – это краеугольный камень устойчивой системы здравоохранения, обеспечивающий всеобщий охват услугами и достижения связанных с охраной здоровья, целей в области устойчивого развития. Казахстан считает чрезвычайно важным предоставить государственным членам ООН и всем заинтересованным сторонам возможность обсудить, как первичная медико-санитарная помощь способствует достижению ВОУЗ и ЦУР. В этой связи наша делегация выступает за то, чтобы одна из 2 интерактивных панелей сессии сентябрьского мероприятия по ВОУЗ была посвящена теме первичной медико-санитарной помощи. Считаю, что первичная медико-санитарная помощь является важным элементом здравоохранения, особенно для тех, кто живет в отдаленных и бедных районах. Кроме того, она играет ключевую роль в улучшении здоровья населения и сокращении неравенства в доступности медицинских услуг. Мы уверены, что такая сессия будет полезна для всех участников мероприятия и позволит нам разработать рекомендации и практические решения для улучшения доступности первичной медико-санитарной помощи и улучшения здоровья населения. Кроме того, заявляем, что Казахстан готов выступить в роли сопредседателя данной сессии, в связи с чем просим присутствующих уважаемых представителей Офиса председателя Генеральной Ассамблеи принять во внимание озвученные нами предложения для учета в ходе дальнейшей подготовки к высокому мероприятию в ВОУЗе в сентябре. Благодарю за внимание.
Thank you, Excellency. Thank you. And now WEMOS, followed by the NCDIA Poverty Network.
Thank you. I speak on behalf of WEMOS, Global Health Justice Advocacy Organization, and Akina Mamawa Africa, Pan-African Women Feminist Leadership Development Organization. The pandemic painfully confirmed what we already knew from evidence-based international guidance. Public finance is crucial for advancing UHC equity and inclusivity, so long as it is sufficient in measure and wisely used. On that note, and with particular view on low-resource countries, we bring in 3 points that require systemic and unified action. 1, take appropriate measures to increase government financing for health, for PHC, for critical services such as sexual reproductive health services. Member States must acknowledge that profit-seeking capital in the healthcare system will not likely achieve the goal of reaching the furthest behind first. 2, to expand countries' fiscal space for social spending, including for health. Decisive global-level action is needed against tax abuse and unsolved debt crises. We recommend that Member States acknowledge this in the UHC political declaration and take steps to implement a UN tax framework building on the milestone resolution on inclusive and effective international tax cooperation and debt resolution framework that binds all creditors and offers comprehensive debt restructuring or cancellation to all countries in need. 3, pursue health financing policies that are deliberately aimed at advancing equitable access for all. Equity is hardwired in the definition of UHC, and so it should be in every country's health financing system.
Member States should express their commitment to a single and progressive, accountable national health financing system, public health systems, and development cooperation and financing partners should support countries in this commitment. Thank you.
Thank you very much. Now we have NCDIA Poverty Network, followed by Transform Health Coalition.
Thank you, Madam Chair. On behalf of NCDI Poverty Network, where a child lives should not determine whether a child lives. And yet, children with type 1 diabetes in rural areas of sub-Saharan Africa often die within a year of diagnosis. This reality is morally unconscionable. No disease should be treated in one country and yet a death sentence in another. NCDs, which now represent the biggest gap in UHC, have been identified as priorities for global health, equitable and sustainable development. Yet, global policies and funding devoted to NCDs still focus almost entirely on diseases on lifestyle-associated risk factors. This global agenda has effectively excluded the world's poorest and most vulnerable populations who suffer a heavy burden of NCDs unrelated to preventable behaviors. For the world's poorest billion, more than 90% of whom are residing in the rural sub-Saharan Africa and South Asia, severe chronic NCDs lead to more than 560,000 avoidable deaths among children and young adults each year. That's more than the number of preventable deaths in this population from HIV, TB, maternal causes combined. Just 4 conditions, type 1 diabetes, sickle cell disease, rheumatic and congenital heart disease, account for as many as 100,000 of those annual deaths. And these tragedies persist even though proven cost-effective treatments have been existing in high-income countries. To address this gap, the NCDI Poverty Network is working to implement the PEN Plus integrated care delivery model in 22 resource-poor countries. This model complements the WHO PEN, which focuses on hypertension and type 2 diabetes. PEN Plus has proven as a commitment to action successful that 47 members of the WHO AFRO have voted to adopt it by the year 2030 countrywide. Yet current resources are not enough. Less than 100 million, just 0.3% of global health spending is allocated to NCDs in countries where world's poorest billion live. It's past time that we form a global movement to better serve people doubly affected by NCDs and extreme poverty. The international community can make the fight against the disease more equitable and just through leadership, policies, and funding that prioritize NCDs within the universal health coverage. Thank you.
Thank you. Thank you. So now we have Transform Health Coalition, followed by the International Alliance of Dermatology Patient Organizations. Transform Health.
Thank you. I'm representing Transform Health. We are a global coalition of 130 organizations. We are calling for digital health and health data governance to be prioritized as key accelerators and components for UHC. Innovative approaches are urgently needed to get back on track to achieve UHC by 2030. This includes unlocking the potential of digital technology and data to strengthen health systems and scale up access to primary healthcare services. Digital health is already an important and growing part of most health systems and offers a huge opportunity to accelerate progress towards UHC. However, equity and human rights must be central to the digital transformation of health systems so that digital technologies and data are made available to everyone to ensure we are closing rather than widening the health equity gap. Transform Health is urging governments and other stakeholders to take the following actions. Prioritize digital health transformation as an accelerator of UHC rather than as a siloed health issue. Close the divide in digital access, including coverage gaps, affordability, and digital literacy. Increase and better target and coordinate funding for digital health as part of the wider investment to deliver UHC, and that should support national digital health strategies. Establish a strong national regulatory and policy environment to ensure digital transformation of the health system and use of data are inclusive, equitable, sustainable, and promote human rights. Work with WHO to develop a global health data governance framework that is underpinned by the health data governance principle, and we encourage all governments to endorse the principles and incorporate them into national legislation, regulation, and policies. And finally, strengthen mechanisms for meaningful multi-stakeholder engagement at all levels of planning, strategy, execution, and monitoring, including youth, women, and marginalized communities. Thank you.
Thank you. International Alliance of Dermatology Patient Organizations, please.
Thank you. I'm pleased to be here today to speak on behalf of our alliance's more than 220 patient organizations in all 6 WHO regions. And I'm here to speak about Action Area Agenda 5, invest more and invest better, particularly as it relates to primary health care for the most prevalent diseases. And this would include skin conditions, and including neglected tropical diseases as an instructive case study. According to the WHO, skin diseases are among the world's 3rd most prevalent causes of illness and one of the top 10 causes of disability. And because there are over 3,000 of these diseases of the skin, hair, nails, and mucosa, these conditions are often difficult to accurately diagnose and treat, requiring special knowledge and skills. With 4.86 billion cases of skin diseases reported in 2019, access to quality, affordable healthcare is essential in supporting a healthy population. This is an especially critical situation because access to specialist dermatology care is nearly impossible in low-resource countries like sub-Saharan Africa, where there's only 0 to 3 dermatologists per million people. Training for frontline healthcare workers who so often struggle to diagnose and treat skin diseases is key to strong, equitable, and resilient health systems. We call on member states to invest more by prioritizing the expansion of dermatology capacity by training frontline healthcare workers to support their citizens. This can be achieved through training, teledermatology support, workshops, and continuing education. This investment would help ensure that frontline healthcare workers are well equipped where specialist care is not readily available. Focusing on these areas of high unmet need will help to create better outcomes for patients all around the world and indeed societies. Thank you.
Thank you. I'd like to call now on the United Republic of Tanzania for an intervention, followed by Mothers to Mothers. Ambassador.
Thank you. My name is Nema Lugangira. I'm a member of parliament from Tanzania, and I just want to quickly state 3 points. Before I start, I would like to recognize and appreciate the endorsement and echoing from Brazil about the importance of parliamentarians, as well as the UHC 2030 efforts towards engaging parliamentarians. And of course, I would like to thank the Tanzania mission here in New York for giving me this platform to be able to echo what I want to say. So number 1, very quickly, it's very important to focus and invest on primary health care, because primary health care is a vehicle towards UHC. And if we do not invest on primary health care, then we're not going to be able to achieve UHC. So I reaffirm the need of strengthening community health systems, cross-border regions health systems, and of course, the frontline workers at community levels. Number 2, as we all know, for UHC to be implementable, we need financing. And when we're talking about financing national budgets, we're talking about parliamentarians. So it's very critical to make sure that in the declaration, it will be very vividly clear on the role of parliamentarians and the engagement of parliamentarians. Because if we are not at the same understanding as you all in this room, then the UHC is not going to be able to progress at our level. And here, I wish to also present an ask. Very common, as we are seeing in this last 2 days, the participation of parliamentarians is low. It's almost minimal. And I am here because of the support of Unite Parliamentary Network on global health. Now, the same way in which different organizations provide travel support for CSOs, I think it is critical to also recognize another key group to provide avenues and travel support for parliamentarians so that more of us can be here and more of our voices can be heard and more of our voices can be represented. Thank you.
Thank you. Thank you so much for that intervention. Mothers to Mothers, followed by OHCHR.
Good afternoon, everyone. Thank you, Madam Chair. My name is Baba Lwampono from Mothers to Mothers. I'm also presenting the collective voice of Community Health Impact Coalition and Front Health Workers Coalition, also a former community health worker. In many African countries faced with shortages in the health workforce, community health workers plays an essential role. Community health workers are also the first point of contact for primary health care delivery and to bridge the gap between the community and the health system. As such, community health workers are increasingly critical to universal health coverage. The study after study have shown the ability of community health workers to deliver integrated, impactful primary health care services. Despite this recognition, community health workers programs across Africa face various challenges, including community health workers who have limited access to resources and material to perform their duties effectively. They're also not receiving fair remuneration for their services, and also limited training and knowledge to provide adequate care in their communities. With Africa facing 4.4 billion annual financing gap for community health, a clear strategy to strengthen community health workers' capacities and ensure their protection, rights, and recognition is urgently needed. Significantly, to contribute to increased access to health services for all under universal health coverage, there is a need for a continued policy dialogue and program planning on establishing supportive structures that enables community health workers to access resources and facilitate their performance. Based on this submission, we call for member states and partners to turn intentions into actions and increase the demand for investments in community health workers to bridge healthcare delivery gaps and work towards realizing health for all through identifying innovative ways to train, deploy, and equip community health workers, improving community health workers' access to medical supplies, medicines, and incentives, increasing visibility of community health workers and how to leverage their unique skills and knowledge for health promotion and disease prevention initiative. We are committed to the areas in the action agenda and urge UN member states to embrace it as the foundation for the negotiating documents for the political declaration on universal health coverage. Thank you.
Thank you. OHCHR followed by Positive Women in Africa Together. And just a reminder to try and keep your intervention to 2 minutes. Thank you.
Thank you. As we mark this year the 75th anniversary of both the Universal Declaration of Human Rights and the WHO Constitution, it is more critical than ever to reaffirm our commitment to UHC anchored in human rights. Madam Chair, we have heard today from many panelists and speakers emphasizing the importance of human rights for UHC and vice versa. Lessons from the pandemic have underscored the critical importance of robust approaches to advancing the right to health, including through UHC programs worldwide, as well as other health supporting rights. For the UHC to be a game changer, UHC should not be understood in a narrow sense. In order to realize the right to health, we must also address broader determinants of health, including water and sanitation, nutrition, and housing. There are compelling and practical reasons why countries should take a human rights-based approach to UHC. Human rights norms are helpful tools for ensuring that laws, policy, and budgets are developed in a manner that is inclusive, transparent, and accountable, responsive to the needs of the entire population, while prioritizing those who are farthest behind. Active and meaningful participation of civil society and marginalized populations are critical. Private sector also have responsibilities to uphold human rights and to do no harm. The work of UN human rights mechanisms offers guidance as well as monitoring and accountability mechanisms. In sum, investing in UHC grounded in human rights not only contributes to improving individual health outcomes, but contributes to greater equality and healthier, more resilient and sustainable society. Thank you.
Thank you. And next, Positive Women in Africa Together, followed by Gavi.
Thank you, Chair. My name is Albertina Nyati. I work for Positive Women Together in Action. As women and girls living with HIV, we ask government to promote models of UHC that prioritize reaching the poorest, most vulnerable and marginalized groups and ensure that all national health policy frameworks address the health needs of these groups throughout their life course. We ask government to specify the populations most left behind and restricted in accessing health services to include the most stigmatized population, using the agreed language in paragraph 25, 60, and others of the 2021 UN Political Declaration on HIV and AIDS. Referring to this population being people living with HIV, men who have sex with men, sex workers, transgender people, people who use drugs, particularly those who inject drugs, and people in prisons and other closed settings. We also ask government to commit to addressing in all health policies, programs, and budgets the compounding and intersecting effects of poverty, gender equality, and discrimination based on various grounds, including race, ethnicity, disability, sexual orientation, gender identity, drug use, involvement in sex works, prisoner status or migrant status, and those left behind. I thank you.
Thank you. A great statement and less than 2 minutes. Wonderful, thank you. Next, we're going to go to Gavi. Unfortunately, that will be our last statement from civil society, and then we will have one final member state statement from Mexico. Gavi.
Thank you, Chair. Gavi, the Vaccine Alliance, is pleased to deliver this statement on behalf of the Immunization Agenda 2030, a global immunization strategy co-led by WHO, UNICEF, Gavi, the UN Foundation, and other partners. It is being implemented through critical partnerships at global, regional, and country level to achieve a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. From 2019 to 2022, 67 million children around the world missed at least one essential life-saving vaccine, and 48 million children received none. Those are also known as zero-dose children. The IA 2030 has the ambitious target to decrease by 50% the number of zero-dose children by 2030. To this end, the immunization partners have launched a campaign called the Big Catch-Up, which will support countries to strengthen immunization system and to restore the historic loss in progress. Zero-dose children and their communities face several forms of deprivation and live in extreme poverty, conflicts, forced displacement, and natural disasters caused by the climate crisis. We should leverage routine immunization as one of the most efficient and cost-effective healthcare interventions, bringing the most marginalized community into contact with primary healthcare. This unique reach is a critical path to extend other essential services beyond the remit of health to the most vulnerable pockets of the population and is fundamental to achieve UHC and ensuring that no one is left behind. IA 2030 is fully committed to building resilient health systems to ensure no child is left behind in having access to life-saving vaccines and primary health care. Thank you.
Thank you, Gavi. Mexico, please.
Muchas gracias. Hoy México se encuentra en la transición a un modelo de salud que tiene como objetivo brindar acceso a los servicios de salud para todas las personas sin distinción. Sin embargo, cuando existe un sistema tan fragmentado en el país, y más aún en los sistemas subnacionales del cual provengo, las brechas son más profundas. El camino aún es largo, pero no imposible. Definitivamente la fragmentación es igual a inequidad. Las personas no distinguen la multiplicidad de instituciones. Lo que les preocupa es que sean atendidos cuando lo necesitan y que sea en el lugar más cercano a su espacio de trabajo o a su hogar. Y lo más importante, que sea gratuito. Pero eso no es posible si se superponen otros intereses antes que la desfragmentación que lleve a una real cobertura universal y que permita la protección de la salud de las poblaciones y de los profesionales de la salud. No seré reiterativa en lo que las personas que me antecedieron ya mencionaron respecto a financiamiento, bases jurídicas fuertes, equidad, inclusión de las comunidades de atención primaria. Pero es importante que en esta declaración para el cumplimiento de la cobertura universal en salud se exhorte a la academia y los formadores de recurso humano en salud y carreras afines, ya que la puesta en acción viene de la mano de quien lo opera en los diferentes niveles y deben, pues, contar con los conocimientos necesarios que vayan escalando a la par de la instalación de estos modelos. Es imperativo que las nuevas generaciones de los diferentes sectores se involucren en estas políticas y en la toma de decisiones. Los liderazgos políticos, tácticos, técnicos, operativos y sociales son esenciales en el camino de la cobertura universal de la salud. No podemos correr en diferentes velocidades. Si uno se queda atrás, puede frenar la carrera de todos. Gracias.
Thank you, Excellency. And I've been told that we're able to extend the session to have some more statements as there's lots of interest. So I am now going to go to the International Association for Dental Research, followed by the Affected Community Network of Diabetic Friends. Dental Research Association.
The International Association for Dental Research, representing over 10,000 researchers worldwide, and the FDI World Dental Federation, representing over 1 million dentists worldwide, thank the chair for the opportunity to present this statement. Oral health is essential to a person's overall health and well-being, yet oral health coverage is often divorced from UHC and the rest of the healthcare delivery systems in many countries. It is important to note that health systems without oral health fail on the health system performance dimensions of equity, quality, responsiveness, efficiency, and resilience. Therefore, health system strengthening for UHC must include oral health care services and financing mechanisms that reimburse oral disease prevention and treatment. This is also essential for the success of the recently adopted Global Oral Health Resolution at the 2021 WHO World Health Assembly and the draft Global Oral Health Action Plan due for adoption at the 76th World Health Assembly. To achieve UHC, we urge governments to integrate oral health and oral health research into national UHC agendas. To reduce current catastrophic health expenditures, it is critical that UHC agendas integrate essential oral health services and the basic package of oral health care within primary care, create an oral health workforce geared towards population health needs and the social determinants of health, and include financial protection and dental care coverage in health insurance packages. Thank you very much.
Thank you. And now we will go to the Affected Community Network of Diabetic Friends, and that will be our last intervention. Is that organization still here? Okay, no? Then I'm going to go to, oh, okay. Please, the floor.
Thank you, Madam Chair, for this wonderful opportunity. I'm representing the Affected Communities Network for tuberculosis called Rainbow TB Forum and diabetes called Survive Sugar. I'm from down South India. We always talk about effective engagement of the communities and the civil societies for success to address any people-centered initiatives. But we often get only stepmother treatment wherever we go. Please look at your civil societies and communities in your own countries and engage them effectively. we continue to tap the doors of the government and all stakeholders for PPPR. Without us, nothing for us. Thank you.
Thank you so much. A perfect note to end on. Without us, nothing for us. Perfect. I would like to now turn to the panel just to give 1 minute reflections before we conclude the session. I'm going to start with Dr. Al-Qodmani because I think your time is tight, so please.
Thank you, moderator. It's quite enlightening to hear so many interventions by the member states and non-state actors. I just want to highlight and conclude that universal health coverage won't be achieved without addressing the social determinants of health and recognizing the impacts of the three C's, which are the global burdens: climate change, conflict, and COVID. We as physicians and healthcare professionals stand ready to support you, collaborate and work together in the preparation of the high-level meeting in September and on the enhancement of the UHC overall. Thank you.
Thank you. Thank you so much. I'm going to turn now, I'll just go in the order that we started. So, Sarah Eve.
Thank you, Chair. Urgent actions and investment in health to accelerate progress towards the achievement of UHC by 2030 are definitely needed. We, as parliamentarians, must and should be ready and in action. There's no one-size-fits-all approach to UHC. Interparliamentary exchanges are a vital part of the process of sharing lessons, providing support, and building parliamentary capacity. The IPU and its advisory group on health will continue to promote the implementation of the resolution on UHC in collaboration with its partners, with an emphasis on the principle of health equity and health as a basic human right. Count on us, and let's do it together. Health for all.
Thank you. Dr. Andriukaitis. 1 minute.
Thank you so much. I am so happy to listen a lot of interventions, like-minded friends. You know, where we are, it is very important now for all of us to understand and to ask a high-level meeting, ministerial meeting to respond, because in 2019 promise was done that service coverage, population coverage, financial protections would be implemented, and now what we have that countries' commitment do not address all those dimensions. Service coverage was addressed by 44%, population coverage by 43%, and financial protection only by 13%. All around the globe. And it means that now commitments, actions, milestones, we need to ask all member states, do you have milestones? Where we are and how can we achieve those milestones till 2030? We need to raise our voice asking responsibility, because globally and locally we see big gap between our promises and implementation. Thank you.
Thank you. Thank you. Alessia.
Thank you, Chair. I heard that a lot of interventions were about primary health care and enabling and supporting frontline workers better. And the front lines can be very diverse. Myself, I am from Ukraine, and the front line is including the war zone. So we as private sector, we are committed to multi-stakeholder collaboration, commitment, and action. And again, you can hold us accountable for this. We invite you to discuss with us how we can leverage our capabilities to help on this road. Thank you.
And Dumi, you have the last word.
Thank you. I would like to acknowledge and affirm civil society represented here. You are amazing. And I will start with a quote by Dr. Paul Farmer. If access to health is considered a human right, who is considered human enough to have that right? UHC 2030's action agenda is clear in guaranteeing gender equity, championing political commitment, and addressing inequities, along with 5 other priorities that ensure people are not left behind as anchored in the SDGs and Africa's Agenda 2063. The time for accelerating progress and action towards achieving UHC is now. This is intricately linked with not only ensuring people are not left behind, but safeguarding and strengthening multi-stakeholder participation, engagement, and accountability with, for, and by people that are most impacted. Lastly, UHC is a fundamental pillar to ensuring a healthy, just, feminist, and inclusive world by 2030 for all people.
Thank you. I'd just like to thank our panelists, our member states, thank you, Excellencies, and thank all of you for your very insightful, inspiring, and pragmatic statements and interventions from the floor. Also, thank you to the President of the General Assembly's office for this great panel and this multi-stakeholder hearings. I am going to bring this session to a close. I invite all of you to stay seated for the closing segment. And thank you again for your commitment and your passion.